I'm Lori Ledley, the founder and president of Valley Sleep Center. And I just want to say welcome to the webinar. If you guys are live on my Facebook, tonight we have Missy Jensen and Laura Link joining us from Respicardia. And they have the kind of newest innovative treatment for central sleep apnea. But specifically tonight, Missy is going to share her message with us about cardiovascular disease and the risks behind untreated obstructive and central sleep apnea and how important that is for our heart health. Really huge topic. They call it comorbid for a reason, right, Missy?
Right, for sure.
So while everyone is getting logged in, Missy, are you able to share your screen?
I think so. Let me get going here.
And I know some of you are interested in our giveaway, and I will email you guys at the end a copy of this webinar, and that giveaway, I'll send in an email after Missy is done with her presentation, once I get it on YouTube. So it might take me till tomorrow, but and feel free to ask questions in the Q&A. This is a webinar format. If you're on Facebook, ask us questions there. It's really kind of a complicated subject. I mean, I already have one, which comes first, the chicken or the egg, the sleep apnea, heart disease.
So talk about that.
Yeah, hopefully you're going to talk about that. And, and also, can our heart disease even be, reversed or helped or anything if we just still continue not to treat our sleep apnea? So lots of curious questions out there, and I'll let you go ahead and get started. Thank you so much for joining us. Respicardia, we appreciate your team. Let's hear the remedy.
Thank you. I love that. Thank you for having us again, Laurie. And as you said, tonight is really more about the connection between sleep apnea and heart disease and sleep apnea. And the importance of diagnosing and finding out and treating if you have sleep disorder breathing of any kind. And I'm going to start with just a quick review that of the two basic or most common types of sleep apnea, and that is central sleep apnea and obstructive sleep apnea. Obstructive sleep apnea is the one that most people have heard of. It's caused, just like the name says, by a blockage or an obstruction, typically in the upper airway or the back of the mouth and throat, that will not let air pass when you try to breathe when you're sleeping. And then central sleep apnea is more of a disease where there's a disconnect between the messaging from your brain to your breathing muscles. And so specifically with apnea, your breathing is normal. You're trying to breathe and move air. But as you can see in the second picture, in this case, it's the tongue that has fallen back, or sometimes the back of the mouth, those tissues can fall back. Sometimes, particularly in children and adolescents, you can have really, really large tonsils that can actually cause this blockage and cause that. And so when you think of obstructive sleep apnea and you look at these pictures, it's easy to see why folks with obstructive sleep apnea tend to snore, because you're trying to move air across this mechanical blockage. So your breathing, it's just an obstruction that causes you to actually stop breathing because the air can't get through. Conversely, central sleep apnea, like I said, it's more of a disease where there is a breakdown of the messaging from the brain down to through the nerves that tell the diaphragm and the other muscles associated with breathing that it's time to take a breath. And this is a really sensitive, kind of not really a vicious cycle, but it's a really sensitive network of the brain getting signals of how much oxygen and carbon dioxide, primarily carbon dioxide, is in your blood at any given time. And it works a bit like the thermostat in your home. If the carbon dioxide and oxygen balance is good and you're breathing normally, then everything's stable. But just like the air conditioner in your home, if one of those drops, so if the temperature drops too low, your air conditioning kicks on, But if it doesn't have the right sensor and delivering the right message, then the air conditioning could potentially run and run and run until the temperature is way out of normal. So this is kind of what happens with the brain. It senses these amounts of carbon dioxide in your blood and sends the signal to breathe. But when that signal is jammed or it's not transmitted well, it causes you to actually have episodes where you stop breathing altogether. And then sometimes other episodes where you're breathing really fast to kind of make up for it. And I have a little animation here. So just to kind of complete the obstructive sleep apnea, central sleep apnea conversation, obstructive sleep apnea is much, much more common, particularly in the general population. However, if you have heart disease, and we'll talk about several different kinds of heart disease that lend itself to sleep apnea in general, but people with heart disease are at higher risk of having this central sleep apnea, and a lot of patients have a mixture of both. And then we have, so these periods of not getting oxygen and then having an arousal where you kind of jerk yourself awake and start breathing again is really what causes the symptoms of sleep apnea. And these symptoms can happen day or night. And a lot of times, particularly if you have some problems with your heart or you're tired all the time and you blame your heart, it really may be hard to comprehend, or you really don't think that sleep apnea could be the problem. But at night, you could have snoring, particularly with obstructive sleep apnea. You could have bed partners witness you pause or stop breathing or gasp. You could have really fitful, restless sleep because you're never really getting into a peaceful, restorative sleep. Frequent visits to the bathroom, very common in people who take fluid pills. They most of the time will have you take your fluid pills in the morning, but I used to have patients all the time tell me that they take their fluid pills in the morning, but they're up all night going to the bathroom. And it's a very common symptom of sleep apnea for a couple of reasons. One of those being when you're waking and sleeping and waking and sleeping many times through the night, as you're having these episodes where you're not breathing, when you wake up and startle, it kind of gives you the sense that you have to go to the bathroom, and sometimes that urgently. And then in the daytime, just really feeling irritable, tired, you can't concentrate. Memory is frequently worse in patients that have sleep apnea. And again, particularly with obstructive sleep apnea, you can get these early morning headaches that just feel like you can't keep your eyes open no matter what you try to do, no matter how much coffee you drink. And then the flip side is, so if you have untreated sleep apnea, you're more at risk for having long-term depression, you're more at risk for developing diabetes, you're more at risk for developing heart failure or congestive heart failure. Again, concentration, memory problems, dementia is more common in patients with untreated sleep apnea. And you're more likely to have high blood pressure if your sleep apnea is not treated. And now for the flip side. So who's at risk for sleep apnea of any kind? And the risk factors for sleep apnea are listed here: high blood pressure, atrial fibrillation, other types of abnormal heart rhythms, in addition to atrial fibrillation, which is a common abnormal heart rhythm, congestive heart failure, obesity. Being a man, men are more likely to have sleep apnea than women. And then if your age is over 50. But look at the first four of these. These are all cardiovascular disease or heart problems. So to your point, Laurie, untreated sleep apnea can result in heart problems, and heart problems can result in sleep apnea. So it is a vicious cycle, and we frequently don't, and a lot of patients don't know which comes first. However, what we do know is that the key to treating these very frequently lies in treating the sleep apnea. And we'll look at some specific examples of that as we go through. So here's some data. Actually, this is from the company that makes the watch pad that Laurie talked about earlier, Itamar Medical. So undiagnosed sleep apnea is a major comorbidity, meaning that it exists in conjunction with many cardiovascular disease. So we'll just go down this list. We'll talk about what drug-resistant hypertension means. This is high blood pressure that you're having a difficult time treating with medicine. 83% of patients with drug-resistant hypertension have an undiagnosed sleep apnea. 76% of patients with heart failure, patients with diabetes, stroke, patients with pacemakers, with heart arrhythmias, abnormal heart rhythms, with coronary heart disease, so heart attacks from blockages in your heart arteries, and then atrial fibrillation, which again is a very common irregular heart rhythm. So we're going to look at a couple of these in specific, the ones that are the most common, and just see how sleep apnea is linked to some of these things. So first we have high blood pressure and sleep apnea. And again, sleep apnea is a risk factor for high blood pressure, and high blood pressure is a risk factor for sleep apnea. About 60 to 80%, depending on what study or research article you read, of people with obstructive sleep apnea also have high blood pressure. And then if you look at all the people with high blood pressure, about 40% of them have sleep apnea. But again, if you have what we call resistant hypertension, and that's defined when you're on 3 or more medications at optimal or maximal doses needed to control your blood pressure. So if it takes 3 or more medications to control your blood pressure, that's resistant, meaning that we need more aggressive therapy to control your blood pressure. And if you have resistant hypertension, you have about a 90% probability of having sleep apnea. And again, we see very clearly when you treat sleep apnea, we frequently hear stories, and I've read many case reports of patients being treated with sleep apnea, with CPAP and other therapies, and able to decrease their blood pressure medicines because it's easier to control blood pressure when the sleep apnea is treated. So atrial fibrillation and sleep apnea. Again, atrial fibrillation is an abnormal heart rhythm that you may have heard of. It tends to cause an irregular and usually a rapid, fast heartbeat. Again, estimated somewhere between half and 80% of all people with atrial fibrillation have sleep apnea. Most of those actually go undiagnosed. Most of those will have obstructive sleep apnea, but about 20% will have central sleep apnea as the type of sleep apnea associated with their atrial fibrillation. And there have been several studies to show that, again, which came first and how these two play on each other. Having untreated sleep apnea also increases your risk of developing this atrial fibrillation arrhythmia. And in multiple studies, it has been shown that treating sleep apnea will improve outcomes for all types of treatment for atrial fibrillation. And those treatment can be medication, or it can be what we call an ablation procedure. So a procedure in the cardiac cath lab to kind of see where the arrhythmia is coming from and treat it with a procedure to get you back into a normal heart rhythm. And all of those treatments are much more successful, much more likely to have long-term success if sleep apnea is diagnosed and treated as part of the treatment plan. So let's look at that a little more specifically with some good graphs. All healthcare providers and researchers love a good graph here. And these are two pie charts looking at one study that took a group of patients who had atrial fibrillation and sleep apnea. And I always feel like the colors are backwards, because to me, green is good and red is bad. But if you look at group A, which is the red, these are patients who had an atrial atrial fibrillation treatment who had sleep apnea and were using their CPAP device. And this is at 1 year of follow-up. And if you'll see the dark red, and this is a European study, so the language is a little bit different for us, but the dark red, just over 76% of these patients remained in a normal rhythm after 1 year, with only, about a quarter, 25%, back in or having persistent atrial fibrillation. And then group B is a group of patients followed for the same period, but through that time stopped using their CPAP. So their sleep apnea was no longer being treated. And you see just almost the opposite. 65%, just over 65 are back in atrial fibrillation or atrial flutter, which is a similar heart rhythm, and almost 35% were in normal sinus rhythm at a year. So clearly having your sleep apnea treated does make a difference in how we can treat and control your heart rhythms. And atrial fibrillation can be a really serious heart rhythm because it increases your risk for strokes. Because the heart is beating irregularly, it can make the blood not flow as well through the heart, cause it to kind of thicken, and that's how it increases your risk for strokes. It can also increase your risk for heart failure or congestive heart failure if your heart is beating rapidly with your atrial fibrillation. So a couple other heart rhythms that people have heard of and that are not uncommon. One group are what we call ventricular arrhythmias or abnormal ventricular heart rhythms. And these are common in people who may have an implantable defibrillator or pacemaker. So common in patients who have congestive heart failure, and also some patients who have had heart attacks. Following your heart attack, you may have one of these implantable defibrillators. But just a few points on what the data shows with sleep apnea and these types of arrhythmias. So patients with heart failure who have sleep apnea are almost twice as likely to have one of these arrhythmias and receive a shock from their defibrillator. And a shock from the defibrillator is a good thing if you're in one of these heart rhythms, because they can be deadly. But again, the point here is that heart failure patients with sleep apnea are almost twice as likely to have these arrhythmias. And these arrhythmias are also more prevalent in sleep apnea patients, even if they don't have heart failure. Sudden cardiac death at night, twice as likely in patients with untreated sleep apnea. And also some data, less data, but some growing body of data now shows that patients who have slow heart rhythms, you can have pauses or heart blocks that cause your heartbeats to slow down to the point that you could feel dizzy or lightheaded. And patients with sleep apnea are more likely to have these types of heart rhythms as well if the sleep apnea is not treated. So now let's talk specifically about heart failure. I think of all of the patients with any kind of heart disease, patients with heart failure or congestive heart failure are probably the most likely or the most at risk for having some sort of sleep apnea. About 75%, so 3 out of 4 heart failure patients will have some sort of sleep apnea. About half of those will be that central sleep apnea where that signal's kind of mixed up and they stop breathing at night. And the other group of those will have primarily obstructive sleep apnea. And again, what we see very commonly is a mixture of these that both need to be treated. And when you have congestive heart failure, some of the symptoms just of that are just feeling really fatigued, waking a lot at night. And again, the patients get really confused. Is it my heart disease waking me up at night and making me feel tired? Or is it something different? And I'll talk about the frequent hospitalizations in the next couple of slides. Patients with cardiovascular disease of all sorts, but particularly heart failure, may not have exactly the same symptoms of their sleep disorder breathing as the general population does. And it could be primarily because they tend to have a mixture of this central sleep apnea and obstructive sleep apnea. Typically, people with central sleep apnea don't snore. So if you're saying, well, I don't snore, nobody ever complains that I snore, you may be overlooking some of the other symptoms that could be pointing to a sleep problem or sleep disorder breathing problem. And like I said, one of the things we see very common in these patients, rather than snoring, is bed partners, family, and loved ones saying, I worry about you every night. I notice that you stop breathing in your sleep, or you gasp or pant. And this can be in and of itself a sign of sleep disorder breathing. So here's this data on heart failure readmissions. And the importance of a heart failure hospitalization is that means your heart failure is bad, it's exacerbated, and typically that means you have a lot of fluid, you're fluid overloaded, and you'll be admitted to the hospital to get that fluid off, and usually to stabilize your medications, and then be discharged. But what we see is that patients with central sleep apnea in the blue, red is no sleep disorder breathing. Patients with central sleep apnea are actually much more likely to get admitted to the hospital, and they're much more likely to get admitted over and again. So again, why that's important is when you're admitted to the hospital, you have worsening of your heart failure. That's the reason for the heart failure admission. So patients with central sleep apnea in particular have more heart failure admissions, meaning more heart failure decompensations, or more worsening heart failure disease compared with patients with heart failure who don't have a sleep apnea. And then one last graph here with regard to heart failure, and this is looking at patients with both obstructive sleep apnea in the blue and then that central sleep apnea in the red, compared to heart failure patients who have no sleep apnea or maybe some mild sleep apnea. And this is looking at death rates, and the higher up this bar is, the better. And so you can see that patients with any kind of sleep apnea who have heart failure have actually twice what we call mortality rate, so twice the risk of death compared to heart failure patients who don't have sleep apnea. So I'm going to leave you with one last set of numbers. 25% of all adults have sleep apnea, but at least 60% of patients with some sort of heart history have sleep apnea, and 85% of those remain undiagnosed and or untreated. So the biggest message here is to get diagnosed, get tested, and even more powerfully, get treated. There are a lot of patients who give up on their treatment. They give up on their CPAP. There are so many kinds of masks and CPAP out there now, and different settings, different mask types. And there are, for both obstructive and central sleep apnea now, non-mask options that can treat both of those diseases. So if you or someone you love has any kind of cardiovascular heart disease, get tested for sleep apnea and then get it treated, because knowing that you have it is not good enough in this particular setting. As I hope I showed you, untreated sleep apnea makes heart disease worse, and heart disease of all kinds. And I think that is my last slide, Laurie, if you want to open it up for questions.
Great. Yeah. So someone asked if you can have both kinds, which I think you talked about, and I privately answered them, yes, you can have both kinds.
Yeah, and in fact, I would say it's actually not uncommon, particularly in patients who have heart disease, heart failure specifically, to have both kinds. Our device specifically treats central sleep apnea. And when we were doing the trial, the research study for our device, we actually broke down how much central sleep apnea and how much obstructive sleep apnea and how much hypopneas, which means you don't actually stop breathing, but you almost stop breathing, your oxygen saturation drops. And we kind of broke all of those down. And many patients, in fact, had some of both. And there are some CPAP and other types of pressure mask therapies that can treat both if the settings are set right.
Okay, we'll continue with questions if you have time. I also want to throw it out there that, in fact, someone's asking, how do we get diagnosed or who orders the sleep study? Well, at Valley Sleep Center, we do everything here. So we're one-stop shop. So if you are interested in seeing one of our sleep doctors or a nurse practitioner, getting a sleep study, we do all that here. All you have to do is either send me a message in the chat, raise your hand. If you raise your hand, I can have a scheduler call you. It's all covered by insurance. And one lucky attendee I'll email you is going to get a free watch pat, which is an overnight sleep study that's done at home. It's disposable. Like the whole pandemic created, although right. Watch pat's been around, it's expensive for us to buy, but yet it makes sense so that it's easier for people to get access and get diagnosed and get treated. And that's really what we're pushing here, right? 85% of all these people who struggle with cardiovascular disease remain untreated. So that's what we're trying to do. We need to help you get treatment. So here's another question. If your AHI is higher, are you more likely to have the heart problem?
So the higher the AHI, the more severe the sleep apnea. So AHI stands for Apnea Hypopnea Index, and it's a measurement of how many times per hour you're having these events of either stopping breathing altogether, or these hypopneas where you kind of drop your breathing enough to lower your oxygen. And it's very likely that the answer to that is yes, because as you can imagine, the more events you have where you're not circulating oxygen and getting oxygen to your brain and all of those things needed, that could definitely put more strain on your blood pressure, more strain on your heart. So again, the AHI is a marker of how severe your sleep apnea is.
Great answer. So I recently had a sleep test with my primary care doctor go over the results. Great question. I would highly recommend that you see a board certified sleep physician or a nurse practitioner who specializes in sleep so that we can really dive into that sleep study. If you had it done here, I'm happy to help. Even if you had it done somewhere else, you can bring it with you and we can go over that with you as well. So everyone, yeah, go ahead.
No, I was just gonna say, I'll tag on to that. Typically, if your primary care physician ordered the sleep study, what they'll get back is a report. And it's just like if you had an x-ray, they wouldn't most of the time look at the x-rays or see the x-ray. What they would get is a report from the x-ray specialist, the radiology, saying, what the findings are and frequently the recommendations. So it's very similar. They may get, a report, a written report that says, this patient has sleep apnea. It very likely may say what type of sleep apnea and the severity of it. But to Laurie's point, to really be able to dig down into how much you stopped breathing, what your oxygen saturation did, and what all of the as we call them, the squiggly lines from your sleep study show, a sleep specialist is going to be much more in tune to that kind of the actual data and what that shows.
So someone's saying AHI is important, but so is desaturation. And what is our protocol for patients who are not CPAP adherent, more they have obstructive sleep apnea? That's tomorrow night. So if you guys want to go to valleysleepcenter.com events, tomorrow night, we're going to talk about the options for non-adherent CPAP people. There's another device for obstructive sleep apnea that's also implantable. And we'll be going over that tomorrow night at 5:30. So if you want to sign up for that, let me know. I can sign you up, or you can just go to valleysleepcenter.com. So here's another one. I had my sleep study done a couple of weeks ago. So I don't want to be included with the watch pat giveaway. Okay. But this was so informative. Oh, it's not even a question. It's a comment. Yeah. Thank you.
Oh, great.
Yeah. Thank you so much for that, April. Anybody else have any last questions or anything that you can think of?
I would add to the DSATs being important. I completely agree with that. We do see sleep studies that, particularly in patients who have central sleep apnea, where they're just not getting that signal from the brain to the breathing muscles, and they actually stop breathing, or they could slow and pause their breathing enough to have these desaturations where the oxygen level that's measured through the little thing on your finger. We do that during a sleep study as well. You may have had that if you've been in the hospital. But yeah, many treatments, I would say all treatments should be aimed at treating both the apneas and the hypopneas because they are important.
Okay.
So Missy and Lori, so we had a question. How reliable is a home sleep study?
I just go to those. Yeah. How reliable is it? Good question. Do you want me to comment, or you want to, Missy?
I think we can tag team it. So I will say that home sleep apnea testing has come a long way just in the past 5 to 6 years. There are some home sleep apnea tests. The WatchPad that Laurie mentioned is one of them, but there are several that can actually at home differentiate between whether you're having an obstructive apnea event or a central apnea event, which is something that we really want to know, because if you're having central sleep apnea or a really complex mixture of both, then we may need to do some further testing and investigation. But I will say, they have come a long way. They're very convenient. They are much more accurate, and there are several that can diagnose or evaluate for both centrals and obstructive sleep apneas. I think that said, the gold standard is to have an in-lab sleep study where you're monitoring your actual depth of sleep and the levels of sleep, as well as your heart rate, monitor you for abnormal leg movements, as well as the breathing issues. So that is kind of the definitive, really extensive testing, and that's usually required for someone who has a complicated or central sleep apnea or a mixture. But the home sleep studies, particularly for obstructive sleep apnea, are extremely diagnostic, extremely reliable.
And I'm a sleep tech and a respiratory therapist. I'm always going to err on the side of polysomnography, which is in the lab study, because we can actually see all the physical parameters that we want to look at, right? We see your EEG, we see your heart rate, we see the tracing of your heart rate. We can, or the actual EKG, we can see your muscle tone. And there's some things that we're limited to when you do a home sleep apnea test. And a home sleep apnea test just does that. It tests for sleep apnea at home. So if you have any other, sleep disorders going on, periodic limb movement disorder, other things, that in the lab sleep study is, like she said, the gold standard. There's there's questions about, I'm seeing a cardiologist. Should I wait until all my tests are done? So I will tell you that we're like the fast track specialty place for sleep. So a lot of other doctors are taking care of your specific issue, right? They're going to tell you, hey, you need a sleep study. But let us take care of sleep. Let your cardiologist take care of your heart. Let your pulmonologist take care of your lungs. Like, we're that sleep specialty for a reason. And we can fast track you and get you exactly what you need. And since our providers here specialize in sleep apnea, central sleep apnea, obstructive sleep apnea, all the different things that we need to look at, it's just a lot better for us to manage that here. So you don't have to wait. You can bring your sleep study that you had done somewhere else and just have a consult here. You can do telemedicine. We can do all this stuff right online. You never even have to leave your home, and it's all covered by your insurance.
And you could definitely be tested at the same time you're being worked up or tested for other, for heart tests or issues with your heart. The one exception to that is if you have been diagnosed with congestive heart failure and you're just starting a treatment regimen, it's probably better to kind of get stabilized on your medicines. For that one specific scenario, if you have a new diagnosis of heart failure, probably better to get on really good heart failure medicines and get stabilized before you get tested. Because I showed you all the data, if you have heart failure, your sleep apnea worsens. But sometimes if your heart failure is treated a little better, you can have changes in those AHI numbers. But other than that, you could definitely get tested at the same time. And then I saw one question about can losing weight fix the problem? Definitely can for obstructive sleep apnea. Also, losing weight, it decreases your risk for high blood pressure as well as diabetes. For central sleep apnea, patients with central sleep apnea tend not to be as overweight or overweight at all. And so losing weight, if you had central sleep apnea, will probably not help that, but it can definitely help obstructive sleep apnea.
I have a question about heart. So ejection fraction, right? That's how we measure heart failure. And for those of you who don't know, I'm a breast cancer survivor. And one of the things that I struggled with was ejection fraction because of the medications that I've had for 2 cancers. And so I printed my sleep study today because we were just talking about some stuff. And so I had a sleep study in 2017. Okay. I had breast cancer in 2015, probably finished all my treatment in 16. So my AHI was only 18. And that was my diagnostic AHI. So then fast forward to 2020 and my AHI went all the way to like 62 because I was struggling with CPAP and all the, in fact, we even put me in the sleep center to make sure I didn't have central sleep apnea because, that
was going to be my first question.
Yeah. So I don't have central sleep apnea, but I just wanted to know, like, if you see that, Missy, with people who have like early or stage 1, I think they call it early stage heart failure. Have you seen their AHIs like overnight get a lot worse? Have you seen? I mean, this is new to me, and I've been doing this forever.
Not exactly. I mean, we do know that again, heart failure patients, ejection fraction just refers to the percentage of blood that your heart pumps with every squeeze. And so 50 and above is normal. Anything below 50 is to some degree abnormal. Less than 35 is what we call severely reduced. And then you can have anywhere in that range. So the reason heart failure makes sleep apnea worse is because particularly central sleep apnea, your brain's looking for that signal of circulating carbon dioxide and oxygen. And if your heart's not pumping because it's weak, then those signals, it makes sense that those signals the oxygen and carbon dioxide signals are not necessarily getting to those receptors very well. But I haven't really seen like that. I can't really blame that big change just solely on the heart failure. Heart failure after some chemotherapies is common, particularly those for breast cancer. And a lot of times we see it get better. Sometimes it doesn't, but a lot of times when you're finished your treatment, it can get better over time. And we use the same medications that we use, say, if you have heart failure because of blocked arteries or heart failure because of years of high blood pressure. But a lot of times we do see that get better. And it would be interesting if you get treated for that, for the weakness in your heart, the low ejection fraction, your ejection fraction gets better. Like, I would love to just make you a guinea pig and do your sleep study again and see what it looks like.
I know, if I just got to make it to the stress echo, all the COVID stuff kind of blocked my
I'm sure. Work. Yeah, definitely have that though.
Yeah. How about hereditary? Is this, do you see this, in family members down the line?
Central sleep apnea could definitely be hereditary. One of our patient ambassadors with Respicardia in the Remedē system is a young gentleman. I think he's in his mid to late 30s now, but his father was approached for our research study several years ago, and his father was older, had really bad central sleep apnea, and his wife and he were taking his father to the visit, and his father just didn't want any procedures. He just wasn't interested. But this guy's wife said, you have all of those symptoms. You have the same thing. So the son ended up getting tested, had severe central sleep apnea with no other, he didn't have heart failure, no other of the common causes. So central sleep apnea can be hereditary. Now, I would say for obstructive sleep apnea, obesity can be hereditary. Big risk factor, high blood pressure can be hereditary, although diet and lifestyle are much more likely to contribute to your blood pressure for the average person. So in that way, I would say maybe obstructive, you could call that hereditary, but mostly you'll see that in central sleep apnea, what we call idiopathic central sleep apnea, just no other cause, but you could see that in families for sure.
So interesting. All right. I think we have how young can a person, we do pediatrics. How young can a person be to get a sleep apnea test? That's one of our biggest, areas of patient care here is pediatrics, because if your child snores, it's not normal. Obviously they shouldn't have central sleep apnea, but they could if they're like early, like a premature, or they have other things going on. Obviously, not something that Remedē would work in a child. This
right. And, we see a lot of adolescents and children with sleep apnea from really big tonsils and adenoids and that kind of thing. I think that's one of the most common, I would guess, for obstructive sleep apnea in children. But there are a lot of children that have that. There are a lot of children that snore. And then there's another good question about, it's kind of long. You want me to just read it all?
Yeah, go ahead. Yeah.
So I have normal to low blood pressure. My resting heart rate is around 60, which is excellent. Goes into the high 40s during sleep, totally normal. So no calcium buildup. So I assume that's like a calcium score for risk of heart disease and nuclear stress test. So great cardiac workup, great heart workup. I'm guessing your sleep apnea is obstructive. I'm guessing, I don't know that. If you can put that back in the chat if you know whether you have obstructive or central sleep apnea. But I would say, even though you don't have cardiac issues now, there's very good data to suggest if you give up on your CPAP and you don't control your sleep apnea, that those things can still develop over time, particularly high blood pressure, which leads to all kind of what we call downstream or further heart problems. So I would strongly recommend you keep taking keep using your CPAP, because it definitely, even though you may not have heart problems now, you're young, you're only 48. And so you want to have all of those great studies when you're 58 and 68 and 78.
Yeah, exactly. Don't give it up. Keep treating it. It's about longevity, right?
Yeah.
This is sort of a different question. If sleepwalking in children can lead to sleep apnea in adulthood, and I'll comment on that, and maybe Missy can back off. So if your child has a lot of sleepwalking episodes, it typically means that they're sleep deprived, or they're stressed, or they're just basically their whole day might be off, or they're having just an interrupted schedule. Sleepwalking is very common in children. Where we watch for it is if it continues into adulthood. So sleep apnea would be totally separate, but could it lead to that? I would just watch your child, maybe put on the video camera or a snore app and see if they're snoring. Obstructive sleep apnea in children's almost always shows sleep apnea. And it is familiar. So if you have sleepwalking in adults in your family, it is genetic. It's very, very rare, but that could go into. But if you have sleep apnea in adults, it is also hereditary. So
great
question.
And I think sleepwalking in general is a like you said, it's an indicator that you're not getting into that really restful REM sleep, where you dream and you have all the restorative benefits of sleep.
Yeah, you're like stuck in what we call delta, like stage 3 sleep.
Yeah.
You're like in a trance and nobody can wake you up, and it's dangerous. Like one of the things we say is, have you ever hurt yourself or anybody else in your sleep? Because that's a problem, right? It's one thing if you wake up, when you're doing it, but if you don't wake up, that's kind of scary. So, all right. I will follow up with a recording and an email so that everybody can watch this later if you want, or share it with your friends. I'll be on tomorrow night at 5:30 with the Inspire team. So if you guys want to sign up for that, and I'll email the winner of the watch pad. A lucky person will get a free diagnosis. So
That's great.
you.
Thanks everybody for joining. Hope that you found this helpful, and go get your sleep apnea treated.
Yeah. And if you have any more questions that we didn't get to, please feel free to email me. I'm here for you. All right. Thanks everyone.
Hi, thank you.
Thanks
Bye.
again, Laurie.